Welcome to Policy and Advocacy on Genetics and Genomics. Today's topic is about should African governments invest in genomic databases for pediatric cancers to improve treatment equity. My name is Philip Maingi from Kenya, and I'm with my colleague.
My name is Aisha Wada, and I'm from Nigeria, and we are on the negative team.
Cancer genomic databases, just this simply means comprehensive repositories of genetic mutations and alterations that are found in various cancer types. These datasets provide foundational baseline for understanding cancer biology across adult population. Pediatric cancer genomic databases are specialized datasets that focus on unique genetic drivers of childhood cancers. Pediatric tumors often have distinct mutational profiles compared to adult cancers, and they usually require dedicated study. The outcome of successful databases is is to have improved diagnostic precision, identification of targeted therapies, better risk stratification, and this leads to more equitable treatment outcomes globally. And that this has been illustrated by Canada on how national pediatric cancer databases can drive clinical decision making.
So our team is of the stance that genomic databases may sound like a cutting-edge solution, but in Africa's current healthcare reality, they are impractical and inequitable. We believe that governments must focus on prioritizing life-saving essentials, such as accessible diagnostics, affordable treatments, and stronger health systems to address immediate mortality, and that costly genomic products will risk draining our scarce resources and leave vulnerable populations without basic care or registries. Therefore, our position is that this is not the right investment for African governments at this time.
Our arguments are based on these principles that these genomic databases are likely to drive genomic disparities. There is issues to do with ethical responsibility. Basic healthcare is more important right now than having the genomic databases, so it will be given priority. Africa needs to have cancer registries first before we start thinking about having genomic databases. We are faced, as Africa, we are faced with specialist challenges. We don't have trained personnel, adequate trained personnel to handle pediatric cancers.
So, going into more detail about our constructive arguments, the first one is about resource constraints. In many African nations, we spend less than the recommended 5% of our gross domestic product on healthcare. There's also considering the high cost of genomic databases because they require advanced sequencing machines, bioinformatics platforms, and secure servers. We also need to consider the opportunity cost. For every dollar we spend on a genomic database, that is $1 that is not being spent on chemotherapy, radiotherapy, or even training specialists such as pediatric oncologists. And these are more pressing issues. The evidence supports this. In sub-Saharan Africa, childhood leukemia survival rates are critically low, and this is largely because many children fail to complete treatment due to poverty, limited access to care, drug shortages, and weak healthcare infrastructure.
We have issues of equity concerns, like urban versus rural defined. These databases are likely to drive a divide between the urban and the rural areas. It is likely to bring exclusion of the rural areas with the benefits going to the urban areas. Then the equity paradox comes in where instead of improving fairness, the genomic databases are likely to deepen inequality. In Kenya and Nigeria, it has been shown that pediatric cancer patients usually present late due to lack of diagnostic facilities. This was shown by a researcher in Kenya called Seference in 2022 and another researcher in Nigeria called Bob Hume and in 2026.
Next, we can talk about the feasibility challenges. We have severe infrastructure gaps in many parts of Africa, with frequent power outages, limited internet bandwidth, and weak data security systems. There is also the human capital shortage, with only a few trained bioinformaticians and genetic counselors available in Africa. There are ethical concerns with the data that will be generated due to weak regulatory frameworks for genetic data privacy and consent. And databases run the risk of becoming expensive archives with little clinical impact. These feasibility challenges show that while genomic data can be valuable, it's the underlying infrastructure and human resource needs that must first be addressed to ensure sustainable implementation in African healthcare systems.
So we are suggesting alternatives for this instead of generating genomic databases. We need to invest more in early diagnosis programs as Africa. We train primary healthcare workers who can be able to recognize leukemia symptoms early and hence benefit the children through treatment early. There is need for affordable treatment and stable supply chains, ensuring that there is access to most essential drugs, the chemotherapy for pediatric cancers, and ensuring that the cost is affordable to the African children. Also, we need to do capacity building, training pediatric oncologists, nurses, clinical officers, and all other healthcare workers who need to be trained in terms of pediatric cancers. Then we need to develop cancer registries. These are very simple to do. They are low cost and they provide actionable data for planning and equity. The impact is this, they will provide alternative directly and this will directly improve survival rates and equity today.
Now, this is our rebuttal. The affirmative team has raised important points regarding the benefits of genomic databases. However, we believe that these points should be considered instead. The first is regarding the clinical accuracy. Yes, in the treatment of pediatric cancers, genetics does matter. But in Africa, children die because of late diagnosis and not because of lack of genomic sequencing. Pathology, cytogenetics, and immunophenotyping already provide accurate and affordable diagnosis, and in this context, genomics becomes a luxury when these basics are missing. Next, we can talk about treatment equity. We believe that equity starts with access to chemotherapy, radiotherapy, and to well-trained doctors. And genomic databases are likely to just sit in urban labs while rural children must still die without treatment. This is now not equity, but exclusion that looks like science. We can talk about health system strengthening. The affirmative team claims genomics strengthens health system, while in reality it drains them. Sequencing machines, bioinformatics servers, and specialized staff cost millions. Strengthening system is about fixing the foundations and not by building castles in the air. The next point is cost effectiveness. Genomics is not cost effective in Africa. The cost of sequencing one child could potentially fund chemotherapy for dozens of children. In low-resource settings, basic cancer registries and drug supply chains will save far more lives per dollar spent.
In our closing statement, we are categorically stating that Africa is not ready for pediatric cancer genomic databases. In order to ensure improvement in treatment equity, it is imperative to strengthen the existing systems and not to invest in the genomic databases.
These are our references, and thank you for listening.